Hello to one and all. This is Atupele Kaponda from the Voice of Muha Scientist podcast, where we make research very easy for you to understand. And today at the house, we have a very renowned professor, Professor Karimu Manji, who is one among our best researchers out there, having over 150 publications and 5 books and over 3 professional lectures. Professor Manji, we are really happy to have you. Good morning.
Good morning, and I'm very happy to be here.
Oh, thank you. So, Prof. Manji, before we go anywhere, we want to know a little bit about you. So, can you tell us a little bit about yourself?
Usually, my CV is 35 pages. So, if you tell me to speak a little bit, means I will spend all the time in the podcast. But to be very brief and to justify the time to share scientific findings, I was born in Tabora in 1959, and I was raised and educated in Dar es Salaam at Muimbili Primary School, at Forodhani Secondary School, at Pugu Secondary School, all government schools. And through the government scholarship, in those times when there was hardly any medical school here, I was getting a government scholarship to study medicine in India, and after I finished studying medicine in India, I came back home, and I'm here ever since 1988. It is my 36th year here, and you know all the milestones from lecturer, senior lecturer, associate professor to professor, and now to emeritus.
Okay, so Professor, we have seen lots of your works that are based on pediatrics and childcare, and we wanted to know if there is any passion, or what's your passion or motivation towards this age group? Why pediatrics and childcare, before we start diving into today's paper?
Yes, as you will see from the paper as well, and from all my publications, over 230 publications, you will find that most of it is focusing on children and newborn babies. I think children and newborn babies are very vulnerable. If you are able to get them early during an illness, you can cure and make them survive with a good quality of life, and therefore improve the whole nation of the future. So children are very vulnerable. If you are a little delay, then you can see the fatal consequences. So they are very vulnerable, they are very much dependent on us, and they are like angels, you know. So I love to take care of them.
Okay, that is so beautiful. I hope you've gotten a little bit of an insight on Prof. Karim's personality and passion towards children. So today, dear viewer, we'll be discussing a paper entitled Morbidity and Unplanned Healthcare Encounters After Hospital Discharge Among Young Children in Dar es Salaam, Tanzania and Monrovia, Liberia. Professor, we would like to get a little bit of an overview of this paper.
So the overview for us to understand is children who are sick and vulnerable, they get admitted to the hospital. They get admitted to the hospital, and we in the hospital setting treat them or find a diagnosis and give the medications, and then they are discharged.
Yes.
But it's very frequent, especially in Africa, that these children, when they are discharged, children under 5, when they go home, they succumb, they die at home. Up to 18%, from 1 to 18%.
Okay.
And when they die, we don't know what happened and why they died. So this study was to look into the potential causes and whether we can prevent death after they are discharged from the hospital.
Okay. Wow, that is really good. And I think most of us never really noticed. I think most of we Tanzanians usually just say it was God's will, and none of us actually thought there is a scientific reason behind it. So
yes, and there is God's will for us to prevent that one.
Okay.
But we don't use that God's will to prevent, rather than we let go. So we should continue practicing, making sure that we save every child at the utmost possible.
Okay. So, Professor, when I was trying to pass through the paper, the time span was 60 days. So I was actually interested, like, what 60 days? Why not 30? Why not 40? Why, to be exact, 2 months after the discharge?
So you can select 6 months, you can select 1 year, but 60 days is an optimal time to see if that increased illness after discharge or even death after discharge is related to the continuum and the level, continuum of what the child was admitted for. So the first 60 days are most likely the continuum of what happened to the child for which he was admitted on the first place. And this is also a very sensitive time for the mother to recall. If you go to the community and ask them what happened last year to the child who died, she will not remember, and they might not know the fine details of what happened to the child until the child died. But 60 days is a time where they can still remember, and also the illness is a continuum. It is a part of the same illness which is happening. So either it was not properly treated or it was a disease which had an effect of causing the death as early as 60 days.
Wow, thank you so much. So, Professor, how did you go about doing this, all this assessment of these 60 days? How did you go about it?
So it was a hard thing first to convince the researchers and also to convince various authorities that we are going to follow up these children after discharge. So they said, like, what will you do and what are you going to? So it was easy that every child who was admitted under the age of 5 years at Muhimbili National Hospital, which is a tertiary hospital, we approached the mother just before discharge, anticipated discharge, or at discharge, and consented the mother that we will follow up you at home by phone. So at 7 days and at 2 weeks and at 2 months to know exactly what is happening to the child.
Okay. And what were actually the findings so after all of that follow-up? Because, dear viewer, Professor Karimu and his team had a very busy 2 years and 3 months of following up lots of mothers and their children. So what were the findings of that very hectic research?
So those children who died after discharge were more likely to have multiple symptoms or multiple illness. So if it was just pneumonia, for example, then they were less likely to die. But if it was pneumonia and malnutrition, or pneumonia and malaria and diarrhea, if there was any additional illness, then the chances of death were higher. That was number one. And number two was if the mother left the hospital against medical advice. Or something like,
I live with my child.
I don't think this child is going to get cured. It's a futile condition. I want to take away my child home. And these children were likely to die. Maybe it is just futile, or maybe it is the cost, or maybe other social reasons. But if those children who had difficulty in breathing, or had diarrhea with vomiting everything, or unable to drink and eat
after the discharge,
at discharge, or the child who had weight loss, they were more likely to die. So it is a big lesson for us.
Wow. And Professor, if we have noted, the age group which you are working with was from 0 to 5 years. So we want to know if this similar problem could occur with children who are above 5. Is it possible, or this problem of morbidity and mortality after discharge is only mainly for those under 5?
So our research focus of children under 5, so we had almost 1,000 children from birth to 1 month, and we had 1,000 children from 1 month to 5 years. But
2,000 children.
So total 2,000 children. But there is a study which has been just concluded by Dr. Elton and Professor Francis Furia, who look at children between 5 and 14 years, and they have very similar findings.
Okay. So, Professor, what we believe, what I and my viewers believe, is that the end of one research is the beginning of another research. So what are your recommendations from this research? What more should be done, should be studied?
So number one, from this one, we need to integrate the care of the children. Okay. Children should not be cut into pieces. This child has pneumonia, this child has diarrhea, this child. Children have multiple problems. And therefore, when dealing and treating these children, an integrated approach of treating them holistically is very important, number one. Number two, to make sure that financial burden and financial issues should not be a cause of leaving the hospital, so that these children do not take medical discharge against advice because they can't afford. So those things should not happen. And number three is, before discharge, there should be a very good counseling on the mother of when to return. Because if the mother sees the child is becoming sicker and she thinks, oh, but I have been told to return after 1 month, so I can't go back in 1 week, then she will lose the child. So to convince the mother, to teach the mothers to be involved in the care of these children, that if you see A, B, C, D, E, F, these are the danger signs in your child, then bring the child immediately back to the hospital.
And if I may interrupt, Professor, in your paper you spoke something about difference in the SALT in medical care. Can you please elaborate more on that before we finish up with the other recommendations?
So there is a difference between seeking medical care. Those children who had difficulty in breathing, they were more likely to be brought sooner as compared to those who had other problems. So difficulty in breathing is a very discomforting situation. So the mother feels sorry and therefore brings the baby sooner. But there are other conditions also, like vomiting everything, not able to eat, lethargy, convulsions, feeling uneasy, abdominal distension, and number of things which the mother should be educated that if you find any one of those things, please bring back the child to the hospital rather than waiting until the child becomes more sicker.
Okay. And every problem is as heavy as it can get, okay? Let's sum up with the recommendations.
So one of the recommendations is to do further larger scale study. This was in a tertiary hospital where the mortality in our study was 3.8%, which is very high.
Exactly.
4 children out of 100 children discharged are dying. That's tremendous. And if you have 1,000 children being discharged in 1 year, that means 40 children are dying. We cannot afford even one child to die. Now, if this is from a tertiary hospital, what about the secondary hospitals where these children are being discharged? All over the region in Dar es Salaam, all over the nation where we are seeing all these children being admitted. So larger scale studies are to be done and more training to be done of what to be done at discharge and to educate post-discharge. This is lacking because in the hospital you have 20 specialists and super specialists dealing with the child. The moment the mother goes home, she's the only specialist who is going to deal with the child. So we need to do a very proper post-discharge counseling and care and a continuum of care back home. I even have a community health nurse who would follow the sicker ones who have been discharged, so that these children are immediately and identified earlier to be brought back to the hospital.
Wow, thank you. And Professor, I haven't heard a little bit about the government, because at the end of the day, as you said, this is a very vulnerable group. It's a group that needs extreme care, and we have seen how the hospitals and how the mother could play a part. So what do you have to say to the government as the mother of all?
The most important thing is to ask and urge the government that children under 5 should be treated free. When I say free, yes, there is a policy of free, but actually it's not free. They have to pay for the CT scans, MRI, ultrasounds, blood tests and things. I think the system should be such that it should be absolutely free, number one. Number two, that the community health workers, the nurses who can go outreach in the community should be trained enough to be able to visit them in the kata, I mean in the different wards in the community, in the various serikali ya mitaa and other things, so that they can be identified and have a good community-based follow-up. This will help to save a lot of children.
Okay. Well, dear viewer, I hope you've gotten a thing or two about unplanned clinical visits and morbidity and mortality after the children are discharged from the hospital. Now, as we are summing up, I have a very, very stubborn question to Professor Karimu. Professor Karimu, I did a little bit of a research on you, and I realized that as a young boy, your mother cooked the best vitumbuas and buns, which were actually renowned. And so far, so good, you still have the recipe.
I do have the recipe.
You can share with my viewers. At least they go out with cooking.
Yeah, you have to make sure that you have to soak the rice overnight.
Okay.
And then next morning dry it for about a couple of hours and then make a powder. And then that rice powder is sticky and wettish.
Okay.
So then when you mix it with the yeast and sugar, it creates a very nice sticky dough. And then you cook it with small fire, with nice oil. It becomes very nice, crispy and delicious.
Well, dear viewer, and that marks the end of our very beautiful episode. I hope to see you next time, and do not forget to like, to comment, and to share it with your friends. This is the voice of Muha scientists, making research as easy as possible for you. Thank you, and see you.